Now ready to listen about existing European mechanisms to support reforms in the countries. And I'm really delighted and happy to have here our good friend, a good friend of the Patient Access Partnership. This is Artur Carvalho from DG Santé, the European Commission, who has been involved from the very, very beginning with the discussions of creating the Patient Access Partnership and many of the initiatives we've been doing together. So really interested to hear your presentation, Artur, and be ready to ask questions a lot afterwards.
Well, good afternoon. Always good to have the post-lunch slot for a long speech, for trying not to get you to sleep. Thank you to Stanimir and to PACT for organizing this, and also to the Bulgarian Ministry of Health. It's a pleasure to be here. In fact, as Stanimir was saying, DG Santé DG Health has been quite involved in these discussions from the start of PACT. And we have been actively involved in this, and also in the MEP interest group on access to healthcare, which is kind of a parallel initiative going in Brussels. I will focus today on three very specific things, but I would just like to say that, of course, a lot of what DG Health is doing has an impact on access to healthcare. And I would mention things, actions, for instance, under the directive on cross-border healthcare, that resulted in the network on e-health, the network on HTA, the European reference networks, but also the work that you saw this morning, and I really recommend you to read it if you haven't yet, the opinion on access to health services produced by the expert panel on effective ways of investing in health, which is a document of extremely high quality. And more specifically, in our daily work, we are also it was mentioned by MEP Kovacev this morning that we are working on a pilot project on measurement of access to healthcare. We are also working on a pilot project on access to healthcare in rural areas. And finally, I would mention something that I will speak on this tomorrow, so I'll just mention it now, but it's also related to this. Which is the health principle that is contained in the proposal for a European Pillar of Social Rights. But as I said today, I will focus on three specific mechanisms for improving access to healthcare. And on doing this, I must say that one thing that I liked in PACT from the start, that it was very clear from the first moment that PACT should have an holistic view of access to healthcare, and that access to healthcare was not only about one thing. So I can gladly say that I will give you a break from all the discussions on pharma and on pricing during the next hour. So these are the three mechanisms on which I will be speaking, which is first the European semester, second, what is commonly known by structural funds, ESIF, and third, the European Fund for Strategic Investments, which is more commonly known as the Juncker Plan, to which I will refer briefly at the end. I start off by the European semester, which is the more interactive of the mechanisms. It's something that that is supposed to provoke a lot of interaction between the EU and the member states. And the EU semester, for those of you that don't know, is basically a yearly cycle of economic coordination between the member states. It's based on the assumption that the level of integration that we have in the EU would benefit for more coordinated action on the economies of the member states and less disparities at all levels in the EU. And from the European semester, The European semester covers these three areas, let's say. The Europe 2020, which you all know, it's the strategy for Europe until 2020, which is an area linked to structural reforms. Then you have an area linked to macroeconomic policy, and you have the famous Stability and Growth Pact, which is more linked to the budget policy. We will focus a lot on the structural reforms part for this presentation. And I start by showing you, I put this not for you to read, but for you to understand that the calendar, this is the calendar of the 2016 semester, so the European semester that just finished in July. And it's a very complex thing. I put this here just for you to understand that this is a partial picture of the calendar. To say two things. First, that there's lots of interventions, lots of interactions between the different actors. And then to tell you that also shows that the main actors in the semester are the European Commission, the European Council, the Member States, of course, and the European Parliament. But there are also other stakeholders. So during this process, there are consultations with other stakeholders at national level that are involved. But I will present you a simplified version of the calendar. That is something that probably you can understand much better. To tell you that the semester process is starting now. So for the 2017 semester is starting now. And the first big step of the semester will be the publication of the Annual Growth Survey, which is a document that defines the priorities for the whole exercise. This is published in November. Then we start the preparation of one document per member state, which is called the country report, which is a document that provides analysis on the challenges of the economies of each member state. And these are published in February. After several interactions with the member state, so there is an initial drafting by the Commission, but then in the process, there are bilateral meetings with the member state, there are meetings with the member state, both in Brussels and in the member state, with stakeholders from the member state. And this results in a technical document produced by the Commission services, which is called the country report. And this country report is in fact the technical basis for the most visible part of the semester, which are the recommendations that then are made to member states in May and July. So March and April, it was not always like this. Until 2 years ago, the country reports were published at the same time as the recommendations. But now the country reports are published in February, and March and April are months for discussion of the country reports before the country-specific recommendations are presented in May. And in mid-April, in the middle of this, the member states present their national reform programs. Because as I said, it's an interaction process. And in fact, this is called European semester because in the beginning, and it's still like this, although the calendar does not correspond anymore to this, there was supposed to be the semester in which the Commission produced the country reports and the recommendations. And then the following semester would be left for the member state to implement the recommendations and to prepare the implementation of the recommendations. And this is why in April, the member states still present national reform programs that try to reply to the recommendations that are coming. So in which the member states identify their own challenges and present the plans for their reforms. Then in May, the Commission adopts proposals of recommendations to the Council, and in July, finally, the Council adopts the final recommendations to member states. So quite a complex calendar that then starts every year. So you see, we finalized the 2016 process in June, July, and we are now already in October preparing the next one. And as I showed to you, the main areas in which health intervenes is basically in the Europe 2020, so in the part of structural reforms, in which I will try to show to you that health although not mentioned explicitly, plays an important role, but also on the part of the Stability and Growth Pact, because as you know, in every member state, health expenditure is one of the major budget lines for that member state. So when we are speaking about sustainability of public finances, of course, the health expenditure always attracts a lot of attention, not only because it's a big budget line, but also because, as we've seen this morning, it has a big potential for growing a lot in coming years. As you may also know, the Europe 2020 strategy has 5 main targets, in which health is not mentioned explicitly, and 7 flagship initiatives. In fact, in one of the flagship initiatives in this Innovation Union, there was a specific health initiative, which was the active aging initiative. But regarding targets, there's nothing specifically on health. However, if we look more closely, we can see that in 4 out of the 5 targets, health plays a big role, or plays a role at least. So on employment, in fact, healthcare represents 8% of the European workforce. When you look at innovation, there's a big potential for research and development innovation in the health sector, which could, in fact, if we see that we have as an objective that research and development represents 3% of GDP in Europe, probably health research and development should represent 0.3% of GDP, which is a big part of it. Then on the target on education, that says that at least 40% of the younger generation should have a higher degree or diploma. And we say, in fact, the health workforce represents 15% of the population that holds such a degree. And then on reducing poverty, again, health plays an important role, and the way we cover the risks for catastrophic expenditure in health plays a big role in reduction of poverty. As regards to the European semester, there's another important part, which is probably the most obscure part of the European semester, but that is official and it's public. So the European semester, the analysis that is made in the European semester is very much defined in thematic fiches. So there are fiches with information for each area that then it's analyzed in the European semester. And these fiches are published every year and they are public. And there is a fiche on health that, if you are interested, it's something that you could also have a look to. So to start the process, and this is probably the moment in which most of the exercise of the semester is defined, an annual growth survey is adopted in November. Last year, the annual growth survey was adopted in November for the 2016 exercise, and this is the document that sets the priorities for everything that is going to happen in the semester. And the annual growth survey last year, in fact, said a lot on health. The semester started in 2011, and so we've had 6 annual growth surveys so far, and this one is clearly the one that has said more on health. And it said under 2 of the sections of the annual growth survey, under investment, in which was clearly said that it's crucial that member states promote social investment, including on healthcare. It's also very clear in the annual growth survey last year that there was a clear link was made between investment in health, between better health and more growth in jobs, which is something that is very important if we want health to gain importance in this exercise. Then there were 2 other mentions to health. One asking for member states to ensure that healthcare is financially sustainable. And then the most important one for us here today, it was said that the reforms that are made in the member states need to continue to enhance the cost effectiveness and to ensure adequate access to health. And then a long list of measures that member states were encouraged to introduce was listed in the document, including several things with impact on health, but for instance, access to effective primary healthcare services was highlighted, effectiveness of health technologies, public procurement, cost-effective use of medicines, but also health promotion and disease prevention activities were mentioned. After the annual growth survey is in place and that we have our priorities established, then the process is to write the country report, which takes from November to February, as I said, including several exchanges with stakeholders, with member states, and of course, lots and lots of exchanges inside the Commission. And then the documents are published, and they are, again, public. They are published, by the way, both in English and in the language of the member state, the official language of the member state, so they are available to everyone. And these country reports basically provide an analysis of the economies of the member states, focusing especially on the challenges that the member states face. They monitor the progress that was made on the recommendations that were made in the previous year, and they set the scene for the recommendations that are then proposed by the Commission in May. And these recommendations in the area of health have evolved along the years. As I said, this was a process that started in 2011. It was a process that was generated mainly with a focus on fiscal issues, on budget issues. And in 2011, there were 4 countries receiving recommendations in health, and they were all in this line. So they were all concerns regarding the expenditure in health and its possible impact on the sustainability of public finances. And with time, in 2012, there were 6 recommendations, 2013, 10, 2014, 16, 11 in 2015, and 13 in 2016. The trend of increasing CSRs shows the importance that health has gained in this process. More important than that for us is that along the way, the recommendations stopped being only on fiscal issues, and we started having recommendations on hospital care, on quality, on access. And another interesting fact is when you look at the reduction in CSRs on health between 2014 and 15, you'd say that there was a loss in importance there. But in fact, what happened is that since 2014, there's been a strong pressure for streamlining the European semester exercise. There was the line that was followed was that there were too many recommendations from member states. And so in 2015, there was a big reduction in the number of CSRs made to each member state. And although the CSRs on health were reduced also, in proportion, health did not lose importance in the European semester. And in fact, last year, in spite of another reduction in the total number of CSRs, there was still an increase in the CSRs for health. Another common misunderstanding that there is regarding the CSRs is that the usual take on a CSR being made in one year and then disappearing in the following year is that there's no problem anymore. So if we said in 2014 that there was a problem of access in one country, and then in 2015 that recommendation disappears, people would think there is no problem of access anymore. And it simply does not work like that. The issue is that, as I said, there are few recommendations that are made to each member state every year. In fact, that number is being reduced. And so now most member states have 3 or 4 recommendations, which means that the recommendations are done according to the priority. And of course, if in one member state you have the banking sector collapsing, which is, as we are in Bulgaria, it's a good example maybe. Of course, you need to have a recommendation on the banking sector, which means that other issues that may have the same importance. It's not the case of health here because Bulgaria still has a recommendation on health, but another issue has disappeared from the recommendations because there is a more pressing issue, but that does not mean that the problem is solved. The recommendations are monitored and evaluated. The progress is assessed in the following year, and that should be where we look to see what has been the progress and not deciding on the basis of the CSR has continued to be there or not. And so this is the picture. You have these are the health CSRs of 2015-16, and you can see that, of course, there's still lots of CSRs focusing on fiscal issues, on budgetary issues, but then you have 6 CSRs on access, you have 8 CSRs on effectiveness and quality, and you have 8 CSRs on efficiency, which is quite relevant and means that health has taken a new perspective with the pass of time in the semester. And specifically on access to healthcare, if you look at the recommendations that were made on access to healthcare, you see that in 2016, different things were saying. For instance, improve the efficiency of the healthcare system by improving access, or advance with the planned implementation of universal healthcare coverage, or just saying improve the accessibility, or pointing to issues of corruption, saying curb informal payments in the healthcare system, or doing it in conjunction with fiscal concerns, saying ensure long-term sustainability of accessible healthcare. And then you can look also, the 2 last examples that are there are from CSRs on access to healthcare that were made in previous years. The first one is quite a comprehensive one, calling for an increase of accessibility, including for disadvantaged people and remote and isolated communities, and increase efforts to curb informal payments, including through proper management and control of systems. By the way, in all my presentation, I avoid saying to which member state this recommendation is made. I did it on purpose. I think it's not useful for a discussion here. And another interesting recommendation that was made in the past was a recommendation to maintain accessibility for vulnerable groups, which was a recommendation that was made in a very specific context. But it's also another interesting way of approaching this issue. And this was basically what I wanted to say to you on the European semester. So it's this interactive process, interactive discussion with member states through which recommendations are made and through which member states propose reforms to adapt their systems to tackle the challenges that are identified in their health systems. The second mechanism I wanted to present you, and I was asked to present you, that can help us to improve access to healthcare, it's the structural funds, the European structural funds. So I think everyone knows what are the structural funds, so I'm not going to explain you what are the structural funds. I'm going to tell you what has DG Health in particular done to help member states, and not only member states, to use these tools to improve their health system. So to tell you what has been done and what will be done in the near future. The only thing I want to tell you about the process of the structural funds is that, as you may know, they work by programming periods. So the period that we are now, it's the period 2014-2020. And how it works, further than the money allocation, is that each member state that signs a partnership agreement with the European Commission, in which the priorities for the usage of funds are defined. This is a long discussion, and at the end there is a document, which is a partnership agreement, defining the priorities. And based on this, there are then documents that are called operational programs, that are basically documents that act as guidelines for the different sectors or for the different regions of the country, that basically set the scene for which are the priorities, where the money will be spent. When this period started, DG Health decided that it would be useful to have a good picture of what is available in the EU and for each member state. So a mapping exercise was launched that has an objective to have a clear picture of what each member state has put in each operational program that concerns health. And this is very important because although there is no specific operational program on health in the EU at this time, more than half of all operational programs, I think there are 313, if I'm not mistaken, operational programs in the EU now, and 173, again, if my memory is not failing me, have something on health. So in more than half of all the operational programs, there is a place to make investments in health. And this mapping exercise, which I will show you a bit more in the next slides what is in there, is accessible through that link that you have on this slide. And this is the information that you find in the mapping report. So an overall assessment, the real mapping of what's in the operational programs for health, the objectives, the sources of funding with a list of all the operational programs, the financial allocations regarding some kinds of health-related projects. I will explain you more why we say some types. And also the contacts for the authorities that manage these funds. So to make it really easy to know where the money is, on what it can be used, and who should the authorities contact to use this money. The structural funds, structural investment funds, as if, are organized under thematic objectives. And this is more to show you that in 3 of these objectives, so on the orange column, you have an objective that includes e-health, and on the red column, you have the first one that includes the active aging partnership, and then the second one, it's called social inclusion, including access to healthcare. So in 3 of the thematic objectives, health is explicitly mentioned. And you see that when you compare the picture of what was the scope of investments in health in the previous period, 2007-2013 and 2014-2020, the current framework, they are not dramatically different, but you can see that there is more on health and it is more on access to healthcare. I said that I did not present examples. I chose one example from a country that is not from the region on purpose, just to show you a bit what the fishes of the countries look like, showing the sources of funding, the scope of investments, the contacts of the national authorities. So it's quite a useful document if you want to know where the funds are available and how can you use them. Another way in which all the funds are organized is that regarding the money, let's say, it is split in categories of intervention. And this, I come back to when I said three slides ago that I was speaking about some types of categories that may be relevant for health. Because in fact, these are the categories that mention explicitly health, but investments in health can be made also under other categories. So the fact that the category title and the category description does not mention explicitly health, it does not mean that you cannot do investments in health under other categories. It just means that, of course, it's more straightforward to do them under these categories. And the contrary also applies. For instance, the one that is underlined, category 112, which is called Enhancing Access to Affordable, Sustainable, and High-Quality Services, including healthcare and social services of general interest, also includes a big part of social services and not only access to health. So these are indicative categories. But if you look at it like this, and if you look at it by member state, and in the bottom you have the total for each category, you will see that there is quite substantial amount of funds available for health. So not only for health infrastructure and e-health, which are the first two categories under the Regional Development Fund, which is something, as you may know, more linked to infrastructure, hard infrastructure, but also under the European Social Fund, which is the second part of the table, which is more linked to soft investments in training and things of the kind. You have the specific title under access to healthcare with 3.7 billion euros allocated, which, as I said, don't need all to be spent in health. But again, access to healthcare can be improved not only through health infrastructure in the other column, or e-health, or the active aging partnership, but also through other categories that a priori are not for health, but for which the money can also be used for health investments. And this is a picture by country by member state, on which you can see the distribution by country and also the distribution by these four types. So the four categories. So blue is infrastructure, yellow is e-health, black is the active aging partnership, and green is access to healthcare. You see in the picture that, in fact, the countries of the region are the main recipients, the main candidates to receive these funds. This is part of the nature of the structural funds. But you will also see, and this is, so in the previous programming period, the two of the categories already existed. And if you compare, you see that the picture changes quite a lot from one programming period to the other. So whereas in 2007, 2013, the member state that had more budget, let's say, for health infrastructure under the European structural funds, structural investment funds, was Hungary. Now it's Poland. So they're, according to the policy priorities also of the member states, and what were the policy priorities that were translated into the partnership agreement and into the operational programs, the picture changed from 10 years ago until now. On access to healthcare, the picture is this one. Again, Poland in first place, but you can see that, again, the countries of the region, all of them basically, or most of them, have foreseen investments to enhance access to healthcare in their operational programs, with one or two exceptions, maybe. Same for e-health, and the same for active and healthy aging. This has been quite, and the reason I put these slides in, so I want to recall that here we are still speaking about the operational programs, meaning that in the operational programs, there are no specific projects. We are still speaking about priorities and the definition of broad definition of what could be the projects in the future. So this was made at the start of the period. But I wanted to give you an idea of what was put in these operational programs as text. So if you see for health infrastructure, for instance, something that was put in the operational program and that to which it was allocated a budget was ensuring access to health infrastructure and improving the efficiency of the healthcare system, or improving access to quality public services, including health. It's this kind of definitions that are in the operational programs. Then you have examples for vulnerable groups, like improving efficiency and access to hospital care for vulnerable groups, or reducing health inequalities, or supporting access to health services. Then you have specific examples for socially excluded groups, notably Roma, in which you have the same kind of things, promoting access to healthcare and public health, including preventive care. And Bulgaria made it more specific, saying increasing participation and promoting access to employment, education, training, health, and social services among vulnerable groups such as the Roma community and immigrants. And then you have the same thing for health promotion and disease prevention, which again, not being access specific, but if you look, for instance, to the last example of Hungary, you have increasing health awareness, especially in deprived areas and among the vulnerable groups. And then you have, for instance, the institutionalization for mental health and e-health, which again, it's another component of access to healthcare. So the conclusions of this exercise were mainly that health is quite relevant in both the funds, so both in the Regional Development Fund and the European Social Fund. As I said, investments in health are more prevalent in new member states, so the member states corresponding to the region, plus Malta and Cyprus. In total, if you look just at the categories, in fact, there is less budget for health infrastructure in this period compared to the previous one, but there is more focus on community-based care, access to care, and active and healthy aging. Then you have the total of the investment, which is not very interesting from here, but to say that although this category of infrastructure is smaller in this period than in the previous, it does not mean that the final investment will not be greater, because as I told you, money from other categories can be used also for health, and that's something we should keep in mind. And this was what was done regarding the past, so regarding what was already set in stone when the study was done, which was the operational programs. What now DG Health is preparing is to do a kind of a similar exercise for concrete things. So to do kind of a mapping exercise for specific projects already being implemented. And then selecting good examples and things that are not, and I mean, I said good examples, not good practices. So examples of things, of knowledge and information that could be useful for other countries with similar problems, with similar projects, with similar characteristics, and bringing them, getting all the parties together and doing some exchange of information between the people that are already implementing the projects and people that will or could implement similar projects. This is a study that the call for it was published in December 2015. There were some administrative hiccups in the middle of the thing, but the evaluation is now being finalized, and the mapping should occur during 2017, and these workshops in 2018. And this to build, the main objective of this is to build the knowledge of on the implementation of the funds, but also on supporting the following implementation of other member states. And some thematic blocks have been defined for this, and you can see the first block of it is it's called Improving Access to Healthcare, with an emphasis on primary and preventive care, and especially for vulnerable groups. Other blocks are related to the effectiveness and resilience of health systems, to the uptake of e-health, research and innovation, health workforce, and active and healthy aging. But so this is the thing, so it's an exercise relatively similar to what was done for the mapping exercise, but for the future. And regarding the structural funds for health, you will have in this presentation some useful links where you can get all this information, not only about the mapping, but about all the generic information that we have on our website, and also the DGs, the Directors General, the services of the Commission that are in charge of the funds. So as you may know, the Regional Development Fund is managed by DG Regio in the Commission, and the European Social Fund is managed by DG Employment. You also have the contact of the email of the colleagues in my unit that directly manage the structural funds for health. And finally, I wanted very briefly to present you the last of the three mechanisms that can support access to healthcare. It's called European Fund for Strategic Investments, EFSI, and it's basically the heart of the investment plan for Europe, which is something that is more commonly known as the Juncker Plan, which is a plan that results from the realization that there is an investment gap in the EU, that there's not enough funds available for investment, and that some projects, because they have a higher risk than most, although they are promising, are not getting done because there is not enough money for investment. As we know, we are convinced that this is particularly the case in health, that you have many investments that are not being made because they're not sufficiently funding for them. And so this fund was created with this purpose. It is kind of a guarantee fund in which, managed by the European Investment Bank, in which the money, the quite significant amount of money that is put into this guarantee fund is supposed to be leveraged. The principle behind the fund is that the public money put in the fund will generate private money that will be invested together with this public money, because having this kind of guarantee to the project, this will attract private investors that will in turn also invest in this project. And what the experience shows and what the expectations are is that in fact this will attract 15 times more private investment than the public money that is being put into the fund. And this would basically translate into an investment of more than 300 billion euros in the 3 years following the start of this investment plan. So this started in mid-2015. The funds are available. They are managed by, as I said, by the European Investment Bank. You have in the next slide, you have all the contacts. These funds are supposed to complement the other mechanisms that exist, also the structural and investment funds. And they are supposed to support, in particularly, SMEs, small and medium enterprises. And health is one of the areas that has priorities defined in this plan. So the priorities for health, for the investment plan, are new models of infrastructure, for instance, primary care, research and development, e-health and new technologies, health workforce, and SMEs. In fact, the start was very promising. 4 of the first projects that were financed through this were health projects that you have listed there, showing that it's perfectly possible to use this fund to invest, to make investments in health that otherwise probably would not raise interest from investors. As I said, you have several links here for the investment plan, for the specific information on health for the investment plan, the contacts of the fund in the European Investment Bank and the European Investment Fund. Because this fund is also followed by a portal that will help the dissemination of the projects, and a hub that will provide advice to the investors, and the links are also available there. And with this, I conclude my presentation. Thank you very much.
Thank you very much for this very interesting presentation for the existing mechanisms. Yeah, so do we have questions from the floor? Everything's clear? Where are the money and how we can use it in our countries? Anyone wants to reflect? If not, I have several. Alina?
Thanks very much for that, Artur. I had a question about the process as far as the European semester, and the process of gathering the information at the country level, and what the mechanisms are that are in place to get that information from civil society sources. And I ask from the point of view of a network again. A portion of our members work specifically in healthcare, and many of them have information they might readily want to share with the country offices, particularly about gaps between stated policy or law and practice. But they tend to be very small. It's not always obvious how to get them engaged in the process, so if you could just say more about that. And I also I had a question about post-2020 and just what is foreseen thereafter, and maybe this is my ignorance, but the extent to which the SDGs are foreseen as something that will be incorporated into some kind of process, the extent to which there may be indicators at the country level, just how that sort of global mechanism or that global process maybe comes together with the EU.
Thank you very much. So on the first question, and as a general principle before going into specific of the semester, we are always interested in getting information from citizens, NGOs, all stakeholders. So all information on specific issues or on member states or whatever are welcome to us. We need that information to complement the analysis we do for the semester and for other things. Specifically for the semester, on top of that, of course, so for that, you need a bit, if you are not doing anything specific for the semester, you need to understand the calendar of the semester to know when you should give us the information if you want it to be, that you have a better opportunity of having it used on the semester. Some entities do it, some people here in the room even do it, so they come to us, they know when we are writing the country reports, and they come to us with information and saying, look, this is what we think is the picture in the different countries, and this is what we think are the challenges. Then there is the more formal issue. So the interaction in the semester is country specific. So the semester teams, have bilateral meetings with the member states during the process, but with governments. And then the semester teams, on top of informal contacts, they do what we call a fact-finding mission to the member states each year. Usually there are meetings set up with stakeholders, not only with the authorities, but with the other stakeholders. And that's a good opportunity to have that kind of interaction. But that's country-specific, as I said. On your second question on the Sustainable Development Goals, I think that's a very good question. That's a very good there will be a lot of discussion on that. The issue is, I think all the EU member states adopted the Sustainable Development Goals. There is kind of an idea that the Sustainable Development Goals apply to countries in other parts of the world, but in fact they are general principles and they apply also here. They apply also in Europe. So I think you are absolutely right when saying that in the future, these goals that were adopted recently and that will stay there for the coming years will have to be translated to the agenda of the EU. And if we think of health, you have all member states adopting a goal in which one of the targets is that universal health coverage should be guaranteed for everyone. So I think that helps us a lot, and I think it's inevitable that they influence the future agenda of the EU.
Hi, me again. Regarding the grants, I was just checking the grants from European Union, and as a patient organization representative, I have a problem. I cannot apply for these big grants. There are millions and millions and millions and euros. From my point of view, and talking also with my colleagues from other organizations, not only from Romania, from other countries in Europe, maybe you can have an idea of having some small grants for educational purposes, for building capabilities. We don't need 2 million euros or something like this. We need 50,000 euros or 100,000 euros, because if we are talking about affordability, we are talking about the access. This cannot be done by the night by our authorities without our pressure. And now we are not in the position to create this pressure because we don't have instruments, or if we have it, we don't have a possibility to bring to all these people all this knowledge. One of the biggest and best European project lately was EUPATI. So now, me and Sarunas, and maybe other people maybe are here, we are EUPATI fellows, yes? So we have all this knowledge. We know everything about HTA. We know everything assessing a new medicine, about clinical studies and so on. But we don't have the possibility to bring all this knowledge to the patients which need more, and also to other organizations which didn't been so lucky to have a representative in EUPATI or other European or international meeting, even like this. For me, this meeting is great, but what next when I'm coming back? I will have no other 20,000 euro to organize a meeting to bring all the organizations from Romania and to have one day a follow-up and a free discussion about what was discussing here and what we can do next, or what we can bring more to a project like this. So maybe your European Commission will take in consideration these small grants, not all the time necessary with this big live participation, like it's have to be 3, 4, 5, 6 countries. So let's say small grants to bring all this knowledge in every country. Thank you.
Good
Thank
comment.
Yeah, I was trying to look if I had something, but no, I don't have any specific example for Romania. Well, there are different things. I guess when you mean grants, you are not talking about structural funds. You are talking about maybe the health program or something. There is also money available from other sources than this. And for instance, DG Health has a health program through which it conducts different actions. But of course, it's a limited budget, and there is money in this budget that is, in the past years, has been allocated to these activities, but to support patients' organizations in capacity building. But it has been done through the Chapeau entity, which is EPF. Another thing is that I think you probably will be able to find not a grant, because a grant is a very specific thing. So a grant is money that is given to one entity for the entity to conduct its activity. But probably, I'm pretty sure that the kind of project you mentioned would fit in one of the operational programs in Romania. So I'm sure that in Romania has an operational program that supports improving access to healthcare, in which this kind of action could fit.
Sorry, why Romania, our government, will give us money to build a society to contest all the time their decision? So I don't think in any country, and by the way, our name is non-governmental organizations. So it means that we are not funding from governmental funds. So we need to be equal and to stand for our beliefs, not to try to smile nice to the Minister of Health for some money to have a conference with the patients, let's say. Yeah, so I'm thinking you are thinking very big, very, very big. No. But finally, everything you can find, it's very small to the normal people day every day. So how we can bring these big things to our level?
This is actually the big question you have to answer this afternoon for the working session, but I do agree with you.
Yeah. Actually. But I'm sorry to disappoint you, but all the EU money is government money. So, so if you are... No, what I was telling you is that if you are saying to me that you cannot receive government money, you cannot receive EU money, because all the EU money comes from the governments. So what I'm trying to tell you is that that the projects that are important for the health systems may be supported by the structural funds, and in theory they should not depend on political preferences. We know how things work in practice, but the main issue should be to prove the value added for the health system, and not if then this will mean that the government policy will be criticized or not. But of course, it should be coherent with the priorities of the country. But I guess improving the access to healthcare, it's both your priority and priority of the country. So I don't see a conflict.
I get your point, and be sure that we discuss constantly within European Patients Forum this also with other organizations, because this is a major problem that many of the small organizations that actually do the work, do the job on the ground, they are there with the patients, they are there with the governments, they know the situation, they have to have the ability and the capacity to do their work better. So it's ongoing debate, and it's no single solution around that, but I think you're right. The focus on the communities, the focus on the people who live there and know the situation should be priority for all of us, no matter who stays in Brussels and who stays on the top of a member state. The priority should be the communities themselves and the citizens. Other question around the topic of the European semester and the structural funds?
Yes, the question is actually about the follow-up on the recommendations, and you mentioned that there is a misperception that the recommendations not appearing about that country considered to be that it's taken care of. So what is the mechanism of monitoring the success and addressing the recommendations so that you have some kind of, also measurement of impact of your semester program?
So, in fact, another very good question. I have, there was something that I meant to say during the presentation and then I did not say, that in fact, one of the problems of the semester for health and one of the issues with the fact that the recommendations on health evolved to another thing than just fiscal concerns is that semester is a short cycle. It's a one-year cycle. And the recommendations we are making cannot be implemented in 12 months. So So in fact, we do monitor, we do assess the recommendations, but we are aware that the recommendations are not possible to implement and to see the results of implementation in 12 months. Having said this, the way the recommendations are assessed are through, so usually what, you saw the examples of text of the recommendations. This usually implies either the adoption of a new law in the member states or the implementation of a already existing law, or both things. And the way, in fact, the CSRs are monitored and assessed is made explicit in the country report itself. So it's the last section of the country report, in which you have a table with the implementation, with the monitoring and assessment of progress in the implementation of the recommendations. And there are like 5 categories, if I'm not mistaken, which vary from no progress to full implementation. And the description of what you mean by no progress or limited progress or substantial progress or full implementation, it's written in the table, and it's quite explicit. So no progress is very easy to understand, full implementation also, but then, for instance, limited progress means that there are plans to pass a law or to adopt a legislation, but these have still not been made. This step has not been taken, or it has been taken, but the law does not seem promising. And so basically what you have is a table with the CSR, a description of what happened, saying, for instance, this law was adopted in May 2016, but still has not been implemented, or this law has been adopted in May 2016, and it has started to be implementing, but it seems like it will not have a major impact. And then you say, so our assessment is limited progress. So there is this assessment, but of course the assessment of progress in implementing CSRs in health, when we are speaking about effectiveness or access, must be much more longer term than 12 months.
Actually, something that is going to continue in the discussions in the afternoon, and this is one of the things you will have as a question for the working groups. How can we make, or can we change somehow, or recommend something to the Commission to change in the semester process so it serves better the local situation and it serves better the reforms in the countries, and vice versa? How we can better provide data, ideas to the Commission. I don't know how structured and popular is this consultation with the public health organizations, patients organizations. How do you approach them, or how the country teams are approaching them? Is it an open process? Is it structured thing, or it's a decision of the country groups? And can we do it in a more structured way and more popular to those people who actually know what's the situation in their own countries?
So it's done it's both structured and unstructured, let's say. It's structured in the sense that every country team does a visit to the member state, and then the country team, which I must explain that the country team has one representative from each service in the Commission. So there's someone from health, but someone from education, someone from employment, someone from economy and finances, and so on and so on. And this team decides which sectors are going to be analyzed. So almost for sure, if there was a recommendation on health the previous year, there will be a meeting on health with the Ministry of Health. And then further to this, there are meetings with other stakeholders. And then the people from DG Health, on the health part, may decide who to invite to these meetings or who to propose to be invited to these meetings. But of course, for other member states that don't have a country-specific recommendation, there are no meetings. Yeah. So in a way, your suggestions would be welcome. I think we are also looking for ways to have more contact with all stakeholders in the different countries. How could we do this in a more structured way? If we can find all together some proposals for this. I think this would be very welcome. In a first step for DG Health, and then, of course, so the 2017 semester is already in motion, but at the end of the semester, of course, there's always a period of reflection on what went well, what went wrong, what can be improved. And so if you are speaking about a major change, we can also propose it at the end for next year to change it. But I think even if only for the interaction between the health stakeholders and DG Health, which we are trying to do more and more direct contacts to get more information directly from the different stakeholders. If we can have good proposals to make this better, very welcome.
So this is a great commitment. Be creative this afternoon and come with good mechanisms for involvement and the opinions of stakeholders, at least in the healthcare sector. Probably this could be expanded also to some of the other your colleagues, because healthcare is directly linked with fiscal policy and the economic results, etc., the workforce.
In fact, usually, so there's DG Health in the Commission, but then there are other two DGs that also pay a particular attention to health, which is DG ECFIN, because of the budget impact, the fiscal impact of health, and DG Employment, both for historical reasons and because it also reflects a bit the organization in some member states that social affairs ministries and health ministries are together. So there's also a part of DG Employment that has an eye on health. So these three DGs are, let's say, the core of the health policy in the European Commission.
Fantastic. So we have very nice topics to discuss and be bright in the working groups. But now we have a short break. 20 minutes from now, I would say. So we go back in the room 5 past 4. We go back in the room to start with the working groups. And I'll explain more details about the working groups and the questions when we come back in the room. So enjoy your coffee. Thanks, Artur.